So the way that I see this and the way that you describe it, Sue calls you. She says, I have a patient that would benefit from Replimune. You look at the scan and you determine what are your what are your first initial targets. And do you pay? So I guess there's an algorithm for how you inject Replimune. You can inject up to, is it 10 mLs?
10, yeah.
And it's based on lesion size, correct?
Yes, there's a soft algorithm that tells you sort of what to do with lesion size, and then the technique part kicks in, right? Like, what do you do with those 10 cc's? But maybe we probably will talk about it at some point.
That's what I was going to ask. So now, so let's say you have visceral disease, abdominal disease, stuff in the liver, stuff and maybe some iliac lymph nodes, stuff that's going to need some type of image guidance to inject. How do you tackle that? What is your thought process whenever you see a patient like that?
So I want to do the simplest, fastest, safest thing for the patient. But I also want to be respectful of process and respectful of what was done in the trial. It is very possible, and I have to look at some of the data, that there's an intent to get some liver injections done, for example, if possible, and not just lymph nodes. And so if I see a distribution, let me keep it sort of simple, of, say, abdominal territory and, say, liver, then I may use that 10 cc and inject a few of the lymph nodes and probably a liver lesion, just to distribute and keep sort of within the guiding principles of the trial. If I'm forced to, then we will go to lung, because lung, as you can imagine, is a different entity, different image guidance, different follow-up, different complication rate. Why, in an asymptomatic patient waiting to get therapy, would I take a 2, 3%, 4% pneumothorax rate? Why would I do that? I'm just embedding, unnecessary delays in the treatment. So I will do that. And then what I have to do, Tyler, is then document it. I've given 3 cc's here, 3 cc's there, 4 cc's there, and I have to document. One of the things that we're going to work with Replimune, again, is to create various algorithms to maybe highlight that more academic centers, the large community centers, the smaller community centers, because, again, we want to make sure from an IR perspective, this is available everywhere. This is not some hyper-specialized procedure that can only be done in the large volume centers, like some of the complex stuff that we do. This is something that can clearly be democratized and socialized across many places. So we will build these algorithms to cover each of these places, keeping in mind sort of their internal limitations. Some places, the IR is doing many, many things. So we want to be respectful of that. But now we have to document that. Now I have to document that this is what I've done, and I've agreed with Sue that on treatment 2, I'm now going to treat this lesion, that lesion, and that lesion. Right. And so there's a plan. And then there's some concepts of, recycling some of the easy lesions. Personally, when we think about the algorithms, and it's going to be based on what the data shows, the subset analyses of what was injected where as part of the trial. If I don't have to puncture a lung unnecessarily, why am I going to do that? Hemoptysis, pneumothorax, etc. Why am I going to do that? So we will be respectful of how the trial was executed, but we want to be practical and safe as well. So all of these things come into play, and I want to set a treatment plan for the next 2 or 3 injections based on for example, a form that we'll have that will sort of draw out where the lesions are. This is going to be treatment 1, treatment 2, treatment 3. It'll be part of the permanent medical record. So all of these things are the things that we're thinking about to make it easy for the interventionalists and to minimize the number of communications. Sue doesn't want me to call her 3 times, nor does she want my partner to call her. We've had a conversation for an hour. Let's be efficient, and let's do it that way. The last thing I would say is I've always been a fan of hyper documentation in my procedural note, particularly when there's a plan. And I sort of devised this when I was early in my Y90 experience, development, and I would always have a very detailed plan such that my partner would know what to do. This is a selective infusion of this. Best way to see the takeoff of that vessel is the RAO 35 degrees. The Cobra does not work in this example because it's a very downgoing celiac. You need a reverse curve catheter. So I would spell it out so that my partner, if I'm not here, and in that case was Dr. Lewandowski, as you know, knows exactly what to do, and vice versa. So I can envision, and I do in these types of reports, I hyper document. This was treatment 1. I treated lesions 1, 2, 3 on the chart. In 2 weeks, we're going to treat lesion 4, 5, 6, etc. So make it easy, minimize sort of the challenges. And once you've gone through a couple of cases, I think it's smooth sailing from there.
You sound like Juan with the hyper documentation. Juan Jimenez, my partner. So yeah, I feel you, and I think I totally agree with you. I think it doesn't hurt to be as specific as possible.